distant and sensitive structures, cavernous sinus, optic chiasma, internal carotid artery, which make the whole procedure very challenging. Let's begin with the preoperative management. The history. Usually, it's a patient coming with a history, either if he has a hormone-secreting tumors, it will be manifested with different hormonal derangements, or he will be manifesting with the symptoms of the space-occupying lesion in the brain, including reduction in the visual field, diplopia, headache, or signs of increased intracranial tension as well in the form of nausea or lethargy. The preoperative assessment, it requires, of course, an ophthalmological evaluation, an ENT evaluation for the nose and the nasal cavity. Examination should also readily identify patients who have major hormonal disturbances. These patients can be either manifesting with Cushing disease or acromegaly. In this photo, on the first side, this is an acromegalic male patient. And of course, you can see the hypertrophy that is seen in the bone and the soft tissue. And of course, we should expect by seeing this photo that this man could have a difficult airway management. The other slide is the other photo is for a lady with a Cushing syndrome, either due to excessive use of steroids or as a result of a pituitary tumor secreting steroids. We will see abnormal and excessive fat deposition all over the body, which might lead to difficult vascular access for these patients. She might have cardiological hypertrophy, which leads to cardiovascular problems. She has pads of fat all over, which may lead to difficulty in the airway management. She has muscle wasting in her extremities, and this makes her more sensitive to muscle relaxant. The preoperative testing, preoperative baseline pituitary hormone panel, and the hypopituitary, hypothalamic pituitary organ axis should be thoroughly investigated with a neuroendocrinologist. We should be doing thorough lab screening for bleeding tendency and the CBC, because it's a very highly vascular procedure. The pre-surgical assessment of the medical comorbidities. Acromegalic patients are well known to develop diabetes mellitus, hypertension, heart failure, obstructive sleep apnea, and goiter. The Cushing patients are likely obese, diabetic, hypertensive, hyperlipidemic, more prone to cardiovascular accidents and thromboembolic events. Patients with hypopituitarism, on the other hand, they are very sensitive to life-threatening hypotension episodes intraoperative, and they have increased sensitivity to anesthesia. We should be expecting difficult airway management as well as the obstructive sleep apnea post-operative. We should take our time pre-operative to optimize the comorbidities. Pituitary surgery is considered an elective procedure even in cases of pituitary apoplexy. The patient and the tumor really give us time to properly optimize the medical condition of patients. Treatment of any rhinitis or infection or sinusitis in the nasal cavity is crucial to avoid post-operative meningitis. We should explain the procedure thoroughly to the patient. We should explain to him what to expect. We should give a hint about the post-operative complications that he might face. These might include diabetes insipidus, pneumocephaly, meningitis, bleeding. There are some rhinologic post-operative sequelae as epistaxis, hyposmia, nasal crusting. Many of these patients come to the outpatient clinic post-operative complaining of the continuous sensation of bad smell in their nose. This is due to the fat that we insert post-operative in their cavity. There might be other complications, including delayed sphenoid mucocele, which may present with retroorbital pain and visual deterioration. Medications. Many of these patients come with a steroid coverage pre-operative. If the patient is on steroid, he should remain on steroid. But if the hormonal profile didn't need steroid coverage from the pre-operative period, so it's not a routine to give a steroid coverage, but the cortisol level should be monitored the first day post-operative, and it should exceed 9 milligrams per deciliter. And this patient should follow up with an endocrinologist to see if he will need later on an hormonal coverage. If this patient is coming and he's already on antiplatelet and anticoagulant, it should be stopped pre-operatively at the proper timing because this procedure is bloody. The intraoperative management, there have been, most of the anesthetists focus on the fact that the vascularity and the frailty of the sinonasal mucosa make this procedure very bloody. Bloody field makes the surgeon unable to reach the tumor properly. There are many literature comparing the total intravenous anesthesia versus the inhalation anesthesia. Actually, most of the literature found no hemodynamic stability difference between the two protocols. However, the TIVA provides a better surgical field than the inhalation because it provides the hemodynamic stability, yet it avoids the vasodilator effect induced by the inhalation anesthetics, which makes the blood trickling in the field less. Up to the present day, controlled hypotensive anesthesia is widely used in this patient, though recently there are great concerns about the hypotensive anesthesia, and many of the new literature states that we should avoid the hypotensive anesthesia. However, it is still used up to the present day in this type of procedures. One study by Hay et al. Examined if the mean arterial blood pressure kept above 60 millimeter mercury, and they found that the velocity in middle cerebral artery is good enough and it avoids neurological sequelae post-operative. High quality evidence states the safe of utility of antifibrinolytic. Many of the surgeons and the anesthetists like to use tranexamic acids in skull-based surgery. The airway management, as we mentioned before, these patients are susceptible for difficult airway management. The OR should be provided with video-directed laryngoscopes and fiber optic endoscopes to help to secure the airway. There have been a debate, strange enough, between using the endotracheal tube versus the laryngeal mask. 99% of the anesthetists use, of course, the endotracheal tubes because it provides a better sealing of the airway and a better protection of the airway than the laryngeal mask, which may be associated with aspiration and regurg. However, still some literature compare the surgical intervention using either endotracheal tube and the laryngeal mask because they say that the laryngeal mask airway used may lead to a better hemodynamic stability than the endotracheal tube. Personally, most of the surgeons I have met, they require, of course, the endotracheal tube use. The head position, the reverse Trendelenburg position has long been supported. It doesn't decrease the mean arterial pressure, but it decreases the venous return and thus lead to a little bit decrease in the incidence of bleeding. 20 degrees head up position is the most widely used, as we can see in this photo. Antibiotic prophylaxis. Standardized antibiotic regimens have been established efficacy in preventing infectious complications in skull-based surgery. Most of the surgeons require coverage of the gram-positive, gram-negative, and the anaerobic pathogens. Recently, this might have changed in the literature a little bit. They only require single drug prophylaxis for 24 hours because the surgical approach through the endonasal transsphenoid is incriminated for a very low incidence of postoperative infection and meningitis. Nasal decongestion and infiltration. This is the part I hate the most about this procedure. We put the patient under anesthesia. The heart rate is great. The blood pressure is great. The patient is relaxed. And then comes the ENT surgeon, and he starts decongesting the nasal cavity, either with topical vasoconstrictors or with injection of adrenaline. And here we go, the heart rate goes high up, and the blood pressure as well. They use very high concentration of these medications. Previously, they used to use cocaine only. Nowadays, it's not common use because there are many risks of using it in hospitals. They use topical epinephrine. Sometimes they add on lidocaine for a better pain control. A meta-analysis by Huang et al. Demonstrate additional optimization to the subjective operative field without hemodynamic adversity with transoral injection of great palatine canal. Personally, I didn't see surgeons doing this approach, but there are good literature talking about it. Transnasal sphenopalatine injection is another common practice that may be effective in improving postoperative analgesia. Surgical preparation. Most of the published literature for the endoscopic skull-based surgery didn't include recommendation for facial or intranasal preparation because it will affect the normal bacterial flora and the normal commensals and might lead to secondary infection. However, the eyes should always kept open, protected, and seen by the surgeon because it avoid and prevent intraocular complications. Most of us put a pharyngeal pack after the endotracheal tube to avoid swallowing of blood because they said that lots of swallowed blood after this procedure might increase the risk of postoperative nausea and vomiting. There are some literature states that there are no difference in the incidence of nausea and vomiting with or without the pack. However, most of the surgeons and the anesthetists in the OR insist on using the pack. Surgical irrigation. The temperature of the irrigation fluid is a great concern in most of the neurosurgery interventions, not only the transsphenoids. Hot compared with room temperature saline irrigation improves surgical field by producing some hemostatic effect, which will actually decrease the blood flow and then the bleeding tendency. Vascular injury is the great fear of the surgeon in these type of procedures. We are very nearby to the internal carotid artery. Most feared and disastrous complication of endoscopic pituitary resection is the carotid artery injury. They describe the use of thigh muscle. They put a muscle flap whenever it happens, and they immediately transfer this patient to neuroendovascular intervention department to be able to do some occlusion or stenting of the internal carotid artery if it happens. Lumbar drain. It's not routinely used to put a lumbar drain in these patients pre-operative. However, if there is a big dural tear seen by the surgeon, he might require post-operative to put a lumbar drain. If the patient comes post-operative with a CSF leak, they examine him again in the operative theater for a repair of the dural tear, and they might use the lumbar drain to decrease the CSF pressure for 3 to 4 days. After the operative procedure has finished, they usually put a splint or a nasal packing. Some centers doesn't use it, but most of the other use these nasal packs. Recovery from anesthesia. It's vital to ensure a smooth recovery, smooth extubation, to avoid peaks in the exacerbation in the blood pressure that might lead to secondary bleeding. We should avoid coughing and sneezing to avoid the CSF leak. Should provide proper analgesic care. These patients raise up with great headache. We usually use the acetaminophen or the gabapentin, and it should be given on regular basis post-operative. The post-operative management. Post-operatively, the patient might experience some mild oozing. It's common, it's self-limiting within 2 days. If there is profuse epistaxis, this patient might be re-examined in the OR again for a posterior septal artery. Then they might choose other absorbent, hemostatic, Surgicel, fibrin glue. If there is major bleeding, as we mentioned before, we should suspect internal carotid artery injury, and this patient should be surgically compressed until transferred to neuro intervention department. Post-operative, this patient should have quite good bed rest, stool softener to avoid straining. This patient should avoid sneezing while mouth is closed, coughing, because this might lead to increased CSF leak. They should be ambulant as soon as it is safe to do so. If there is CSF leakage, as we mentioned before, they might be re-examined for dura repair or a lumbar puncture. This fluid, if it appears post-operative, it should be collected and tested. Post-operative antibiotics, nowadays they usually use it only for 24 hours. Post-operative, the patient should have a thorough neurological assessment, the visual acuity, the visual field. If there are, by any chance, visual complications, they are sent to radiology department to do a CT or an MRI follow-up. Some of these patients, as we said, suffered from obstructive sleep apnea. If my patient is one of these candidates, he should be put in the ICU with a pulse oximeter monitoring for at least 48 hours in neurocritical care. Post-operative, these patients are not candidates for nasal cannula or CPAP devices because this might lead to pneumocephaly and tension pneumocephaly and might increase even the CSF leak. Post-operative, these patients should be examined for nasal care 1 week after the operative procedure, especially after removing the nasal packs. If these patients were already on antithrombotics pre-operative, they can resume the antithrombotic medications 1 day after surgery unless there is ongoing bleeding or the surgeon has fear of some vascular injury. Sodium management, this needs a lecture by its own. It's one of the most sophisticated sequelae in the pituitary procedures. Patient presents either with hypernatremia post-operative or hyponatremia. If the patient is hypernatremic with increased urine output, we should suspect central diabetes insipidus. Many of these conditions are self-limited. If it's not, we should monitor sodium level, do proper replacement, and we might even use desmopressin or the Menorine. If the patient presents with hyponatremia, now is the issue because there are two syndromes, the SIADA or the syndrome of inappropriate ADH secretion and the cerebral salt wasting. In the SIADA, the patient is euvolemic hyponatremic. In the cerebral salt wasting is hypovolemic hyponatremic. The SIADA requires watching the urine output and some fluid restriction. The cerebral salt wasting, on the other hand, requires fluid repletion and plus or minus fludrocortisone. When to discharge the patient? We will discharge this patient once it's fit for discharge, no CSF leak, no fever, no signs of meningitis, no visual field defect, hemodynamically stable with proper sodium level. What is his follow-up schedule? He will be seen in the outpatient department 1 week to remove the nasal packs, 2 to 4 weeks later on to inspect the healing of the cavity and to do some nasal toilet. Long-term follow-up with endocrinologist is required, and of course, follow-up of the serum sodium for the first 5 to 7 days post-operative. In conclusion, attention to detail in the perioperative period provides better care for this patient undergoing endoscopic transsphenoidal dissection of pituitary tumor, and it will help to minimize the complications and maximize therapeutic outcomes. Thank you.
شكرا صافي. سامعني كده؟
أنا سامع حضرتك كويس.
شكرا يا صافي، المحاضرة هايلة على سبيشال من الكلينيكال اسبكت اوف فيو. لغاية لما تيجي بس أسئلة. Okay. My comment on Dr. Safi's lecture is about hypotensive anesthesia. I would like to advise my colleagues that we control the field of surgery by the setting of ventilators and controlling the blood pressure by drugs. This is my experience. Setting the ventilator by decreasing the intrathoracic pressure, using the most lower tidal volume, the most lower respiratory rate, least I ratio, we can control the field of surgery. This is in many times more important than controlling blood pressure. We control blood pressure using drugs. We control the field of surgery by controlling the setting of ventilator. Second comment, that after many literature about hypotensive anesthesia, the conclusion that blood pressure, systolic blood pressure 70, mean blood pressure 50, diastolic blood pressure 30 as a lower limits acceptable, as a safe limits is acceptable in healthy patients to use. Beyond this figures, this is some risk, but 70, 50, 30 are safe figures to control blood pressure intraoperative in healthy adults without end organ affection. Thank you, Sophie. I want to ask you about the fluid management in diabetes insipidus. Post-operative fluid management in diabetes insipidus after transplant surgery.
Well, actually, it's based on the amount of urine output. If it's a very high urine output, we usually try to keep this patient on a no more negative balance than 500 ml. It requires monitoring hour by hour for the urine output, and either we use half volume replacement or 3/4 volume replacement with fluids containing low sodium content. We monitor the sodium level every 4 hours. We use marine PRN or steadily according to the patient condition. If the patient is fully conscious and aware and not requiring assistance, usually we leave him to drink by his own and correct himself, and it is a self-limiting problem. If this patient is not fully conscious for any problem that happened intraoperative or not very cooperative, and then we have to replace some of the urine output.
Okay, thank you. I don't